This will be a kind of overview on different cancer therapies, after which we will study somewhat in detail about molecularly targeted therapies. So that is the idea. So this will be a kind of overview, as I told you. Specifically, we will take up molecularly targeted therapies in the next lecture. So of course, one of the things that people always think that cancer is not curable or something like that. But if detected early, it is curable. The one problem is that it's not a single disease. People say it's a collection of hundreds of diseases, and what it means is that multiple genes are involved. So correcting one gene alone you may not be able to correct the condition. There are exceptions to that. I will talk about it later, as I just told you. Basically, cancer therapy aims at complete cure. Maybe it is not achieved in all cases, but that is what is the major aim. And then, if that is not possible, at least prolong the survival. Another aim is to alleviate the worst symptoms at least. If you cannot eradicate all the symptoms, at least eradicate the worst symptoms. In the worst case, if you cannot cure and if you cannot even eradicate all the worst symptoms, then what people generally do is to alleviate the pain and also rehabilitate them, the patients. So these are the various ways by which cancer treatment is generally given. What is called palliative therapy is very popular. It's not aiming to cure the patient, it is only just reducing the pain and then ultimately to just give them some kind of rehabilitation. So these are the aims. The three major conventional approaches, as we already discussed, are chemotherapy, surgery and radiation. So these are the standard conventional treatment methods. What are the major challenges or issues? Of course, the most important challenge is the specificity. One of the most important challenges is to selectively attack the cancer cells. How do we selectively target cancer cells that are almost identical to normal cells? Remember, cancer cells are not alien cells. They are our own cells which have undergone certain changes to get transformed into cancer cells. So basically, it is our own cells. So that is why the specificity becomes a major challenge. Many anti-cancer drugs generally target rapidly proliferating cells. So what happens? They cannot distinguish between rapidly dividing cancer cells and rapidly dividing normal cells. So that is the major problem, because some of the normal cells may have high turnover, such as bone marrow cells, epithelial cells and so on. This is why you get the side effect, because even those high turnover cells, even if they are normal cells, they will be affected by the anti-cancer agents, and so this is what is called a side effect. You get hair loss, bone marrow depletion, immune suppression are the common side effects of anti-cancer therapy. So basically, the side effects of anti-cancer agents are due to lack of specificity. So we have to know what is the maximum dose tolerated by the patient. You have to strike a balance between side effects that are tolerated. Actually, many of the anti-cancer agents that are in use have side effects. So the medical fraternity wisely uses them, because by their experience they will look at the gender, age, the family history, everything they will take into account. By experience, they know what is the tolerable side effect. So, once that is decided, then they can achieve the maximum efficiency of the drug with the given condition. For example, it is very common, radiation is given at a certain dose for generally for the patients, but if the patient happens to be, say, in his or her 80s or 90s, very old people, then they will not give the same dose. They will reduce the dose, and maybe they will increase the number of days for which the radiation is given. If it is 20 days for a middle-aged person, very old person, they will give lesser dose, longer time. So, like that they will devise the therapeutic protocols. The other problem, major challenge, is the resistance and then relapse, the secondary, moving into the secondary site. Even after so called complete remission, the patient is treated, and after 5 years you get no symptoms, so you think it is a complete remission, but then after 10 years you get it back. So, relapse, that is called relapse. So, that kind of problems are also the major challenges. How to avoid that, how to prevent metastasis, whether a particular person will turn metastatic or not, that is a $1 million question. It is very difficult with the symptoms as well as with some molecular markers. It is still a challenging task to do that. So, what will you like? What is the ideal anti-cancer drug? Of course, you want them to kill all cancer cells, but not normal cells. There is another, with the recent theory advocating cancer stem cells as the initiator cells. These anti-cancer drugs should be able to target cancer stem cells and the quiescent cancer cells which escape the usual treatment. So, that is also ideally, this is what we expect from an anti-cancer drug. Since cancer is a multi-stage process and many signaling pathways are involved, you would like the drug to target multiple pathways. You do not want to take a drug which will attack only one pathway, signaling pathway. There are exceptions, as I told you, but we will discuss that later. But generally speaking, you generally look at multi-targeted treatment. So, it should target multiple pathways. Of course, as I emphasized, they should not kill normal cells, including the high turnover cells. Is there any way that we can use certain chemicals or some type of treatment, radiation or whatever, so that you do not affect the normal cells, even those which have a high turnover, and they should not have any toxicity and side effects. Above all these things, they should also have a good bioavailability. This is also very important. For example, I told you about curcumin, which is very good in combination with standard anti-cancer agents, but one of the problems people face is that once you take this turmeric or curcumin, it does not go into the bloodstream that much, it goes into the feces. So, that means the bioavailability is less. So, you have to find out ways to overcome this challenge. So, these are the general difficulties, these are the characteristic features that you will expect from an anti-cancer drug. Okay, now we talked about the drug. What about the target? How the target should be? Naturally, the target should be susceptible to the particular drug, right? And the drug should not affect other targets, what is called off target, people say. But there are several limitations in choosing targets for chemotherapy. Many drugs, which are often the preferred ones, usually are low molecular weight organic compounds. They almost always inhibit many biochemical functions, because you may call certain chemicals as specific to certain things, but in reality you will find that they affect some other functions also. You will not know, because there are thousands, millions of chemical reactions taking place in the human body. You may not have a system where you will be able to check everything. It's very difficult to analyze that. So you only do it by kind of trial and error, give it to some animals or tissue culture and mice and so on. Again, people will criticize mice is not human, something like that, which they are right also. But then what else to do? You have to do certain things before you finally end up with human beings. Once you are sure that it doesn't affect many of these systems, then finally you try to give it. There also again people try with those which are almost in a hopeless condition. That is what it means, is that they have tried all kinds of treatment. Now they are thinking, you give anything, it's okay, anyway I am going to die, something like that. Those kind of people are again they are the ones who become volunteers and then they take up such and some treatment. The recent ones are these antibody therapies. They have worked out beautifully in them, some of them. This so-called CAR T cell therapy is becoming very popular. That has given life to those people in this category that I mentioned. Some of them survived. So it happens, sometimes it happens also. Naturally, the oncogenes and oncoproteins are the logical targets for many anti-cancer drugs, because we know people have discovered many oncogenes and oncoproteins. So they are the ideal targets. Once you know that the patient is having a very high activity of certain oncogenes, they are ideal targets, because once you target them, then you probably will be able to treat the situation. While doing so, you want to look at the biochemistry of the protein that may become an effective target. How do you look at certain structural features? For example, if that protein has an enzymatic activity, then the best way is to inhibit that enzymatic activity. So the catalytic cleft in that enzyme could be an ideal target. For example, if it is ATP binding pocket, you can give inhibitors of that pocket, thereby you may be able to target it. Now we have studied several signaling pathways. You can see how these signaling pathways, the knowledge about these signaling pathways are useful, because you can use inhibitors that are known to block those signaling pathways. One of the most important signaling pathways are the so-called EGF receptor signaling pathway. I told you they are also called, the receptors are also called ERB receptors, erythroblastosis virus, from which these were originally derived. So the name ERB. There are 4 receptors in this family. The first receptor is EGF receptor, which is also called ERB1 or HER1, meaning the human counterpart, human EGF receptor 1. So you have 1, 2, 3, 4, HER1, HER2, HER3, 4, HER4, ERB1, ERB2, ERB3, ERB4 and so on. These are the namings. Or you can say EGF receptor and the receptor 1, 2, 3, 4, like that also you can say. So accordingly, one of the most important blockers is the second receptor, which I told you, a orphan receptor, HER2 nu, as it is called, ERB2, HER2, nu, all these names are there for that receptor. An antibody against it is in the clinic, which is called Herceptin. So receptor monoclonal antibodies are popular. Sometimes you have 2C4, C225, ABX, etc. So these mostly affect the EGF receptor family receptors. So you could use specifically anti-HER1, HER2, HER4. Most of them are, obviously these are receptor tyrosine kinases. So, they are tyrosine kinase inhibitors. The other aggressive pathway that we have studied is the RAS MAP kinase pathway. So, RAS inhibitors also can be used. RAS farnesyl transferase inhibitors. There are some commercial names given here, you do not have to worry about the commercial names like such as B1, 214, 662. These companies give some names. Similarly, RAF pathway I told you, so RAF inhibitors, the so called BA439006 is one of the known inhibitors. Similarly, MAP kinase inhibitor, MEK, you know, MEK is nothing but MAP kinase. So, MEK inhibitors. You can also, we have not discussed this, the so called mTOR pathway, which is also involved in growth. mTOR means mammalian target of rapamycin. This is another signaling pathway which we have not discussed, but it is also related to growth, and so you have mTOR inhibitors also being used. Basically, all these kind of signaling pathways end up in cell cycle progression, or they may help in survival, or they may simply help in proliferation. So, these are the three important outcomes that you want to block. You want to block cell cycle progression, you want to block survival, you want to block proliferation. Basically, this is what people do. Of course, one more thing is there, that is what it can be. No. Apoptosis is all right, survival comes under that. What else you can think of? Not mutation, metastasis. So, anti-metastatic. For that, people have tried to block what is called epithelial mesenchymal transition, EMT. We will talk about that later, perhaps I will tell more details about that at a later time point. Apart from this, there are different types of anti-cancer drugs. One is the signaling inhibitors I told you. When we discuss the molecularly targeted therapy, we will discuss more details, but as I told you, this lecture gives an overall view of the various anti-cancer agents that are commonly used. Some are alkylating agents such as the cyclophosphamide. Some are anti-metabolites such as the 5-fluorouracil, which is used in colon cancer. Cell cycle arrest like vincristine, which can interfere with that. What is called irinotecan, which is a topoisomerase inhibitor, and in some cases you could use antibiotics even, doxorubicin. So, these are the usual anti-cancer agents that are used. Now, how will you identify a drug for a particular cancer? Because you see, each cancer patient is different, each cancer is different, the molecular alterations in each type of cancer is different from the other, right. In certain cancers, there may be certain set of oncogenes that are upregulated, certain set of tumor suppressors that are suppressed, and so on. I told you the 4 important genes that are involved. What are the 4 important genes? Oncogenes, tumor suppressor genes, apoptosis regulators, DNA repair genes. So, there are about 300 genes involved in cancer, but they will all fall under this category, broad category. There may be slight exceptions, but broadly you can easily accommodate them into one of these categories, one or more also sometimes of these categories. For example, something can be involved in DNA repair and may be involved in apoptosis regulation also. So, more than one category also they may fall in, but they will ultimately fall into one or more of these 4 categories that you have to keep in mind. So, a rational drug design can be achieved by certain computational methods. So the computational methods, they reduce your burden of doing any experiment. Before doing experiment, you have so much genomic database is there. Now you have the so-called TCGA, the Cancer Gene Atlas. TCGA database is there. Now people have worldwide, they have collected so much data. The chemicals also, you have a big chemical database, thousands and thousands, maybe millions of chemicals are there in that database. And whatever people have published, those are also stacked into different databases. So as I often used to say, apparently it looks nonsense because you see so much data, you don't know which one is going to affect which one. So it at the periphery or at the first look, it looks like a nonsense, but from such nonsense data you make sense out of that. That is what the computational designers look at, because they go with some logic. They look at some of the structures of the chemicals and the probable targets and see whether they will actually fit in, because without such fitting in, the drug is not going to work unless there is a structural compatibility, just like a lock and key. A key will not work with any lock, it will work only with the lock that is designed for it. So in a similar fashion, this is also looked upon. So computational drug design, which is what they call rational drug design. The rational is structural similarity, fitting with the structural features and all that. So that is one way. Testing on cell models to determine the selectivity. For example, you could look at normal cells versus cancer cells. Ideally, a drug should be more effective on cancer cells, less effective on normal cells. So at least relatively will they be working on that. So you can determine the selectivity. You should also know the therapeutic index. Some people call therapeutic window also. That is the range of the dose to which the animal or whatever organism you are testing on will tolerate. There are many methods. If you do something in mice, there are people by experience, they will tell you, if you have used this much on animals, this will be the therapeutic window for humans. You predict, because you have done it for several compounds. So you may be able to predict that window in which it is very likely to be effective. So like that, people do it, therapeutic index. Like solubility, bioavailability, all those are also important, because a drug may be fantastic drug, but if it is not available to the patient after some intake again, which route you are going to give? Oral, subcutaneous, or you are going to simply inject, or you are going to put it to that particular site by some method. So those have to be subcutaneous or whatever, intravenous. So the route of administration and the dose, time for which you are giving, and the bioavailability, solubility, all those things, whether whatever you are giving, will it be destroyed by the system? Because for example, if you give insulin through oral route, it's a protein, so it will be attacked by proteases and will get destroyed. So necessarily you have to give it, or you have to modify it in such a way that it is not attacked by those enzymes, and then give it orally. There is what is called oral insulin preparations. If not, you have to inject only. So like that, it depends on testing on animal models. Animal models, just now I told you, the in vivo action of the drug is to be tested, toxicity should be tested, the therapeutic window has to be ascertained, and what is called the so-called pharmacokinetics and pharmacodynamics has to be determined. These two words some people will get confused, but I have given a simple definition. When you are giving a drug, you want to know what the body does to the drug. That is what is called pharmacokinetics, because body does many things. If you give a drug, it may simply, what are known as efflux pumps are there. It will pump them out from the cell. So, whatever you have given, although it is a good drug, it is a waste because it is pumped out by the cells. So, the body has rejected it. So, no use, right? You have to come out with the other method so that it is retained. So, pharmacokinetics, the study of that is called pharmacokinetics. That is very important. There is another one, pharmacodynamics. Before giving that, you should know what the drug will do to the body. So, what the drug does to the body, what the body does to the drug, both you have to know, only then a drug will be effective. That is what in simple terms pharmacokinetics, and there are experts for this. It's a specialty, people are there. Before you ascertain a particular chemical which is found to be effective in your cell culture systems or whatever, you have to know these things also. Only then finally, that is why it takes a very, very long time and lot of money to bring something to the market. Even if you discover something very novel, it's a Himalayan task to bring it to the market. So, that has to be kept in mind. And that is why you have what is called clinical trials. Again, it is not easy, each one has a duration, phase 1 trial, phase 2, phase 3 and so on. So, finally only it can be given ultimately to the patient. So, therapeutic window has to be determined, I already told you. Therapeutic index, therapeutic window, both are more or less same, but therapeutic index will give you that range, but therapeutic window, what is the selected range? What is that ultimately? Whether you will have side effects, whether you exceed that dose, what will happen? That knowledge is necessary to determine a particular window. Okay, you know the therapeutic index, but therapeutic index is a range. Within that range, what is the window you are going to use? So, it may have a index may have a upper range and lower range. So, you have to select a therapeutic window to apply on the patient. For that, you should have a knowledge. If you use the lower range, what will happen? If you use the higher range, what will happen? So, like I told you, what is the tolerable side effect? So, that has to be understood. So, in the phase 1, usually it is many of these studies that we do in the in vitro, all kind of studies, preclinical studies have to be confirmed in this phase. Phase 2 and phase 3 mostly focus on the efficacy, including any indications, anything is there, improvement over existing drugs. What is that? If you are giving some drug, is there any improvement than what is being used already? Is it something better or not? That has to be ascertained. Of course, we are not going to study the whole details. The major problems I mentioned repeatedly is that in vitro conditions often do not reflect in vivo conditions. In vitro it might work very good, or the reverse also. In vitro it has not worked, but it will work in vivo also. It is possible. Do not think in vitro, if it does not work, you cannot say it will not work in vivo. There are situations like that also. So, metabolism and clearance of the drug is not reflected by the cell cultures. Why they are not reflected in cell cultures? Cell cultures are isolated systems. After all, a cell in the culture does not see a blood vessel or another organ or some stimulation from the nerves. It does not encounter all that. It does not have the exact cellular microenvironment that is seen by the cells in the organism or in the body, whatever, in the animal, plant, whatever. So, that is a drawback. But then why people are doing it? Because our past experience, history tells us that if you do even experiments in Drosophila and C. elegans, you do learn very good lessons. They have been helpful. It is not that they are totally nonsense, but they are done with the knowledge of these limitations. One should be aware of the limitations and then necessarily they can carry out. because certain things cannot be done in humans directly. Suppose I suspect some drug, I cannot just like that give it to somebody and check it out before doing all these things. If it is very toxic and if it takes away one life, then it is a very serious thing. Ethical considerations are there. Toxicity and side effects are not often predictable at the cell model stage. It's obvious. Drug resistance. In tumor, some cancer cells might escape the action of the drug. Such cells can form the tumor again. We have discussed that, and I have also told you that some cells may be insensitive to the drug. You remember I told the tumors can be polyclonal. So, some clones may respond, but some other clones of the cancer cells may not respond if it is polyclonal. Quiescent cancer cells in G0 phase often escape the action of anti-proliferative agents that we have discussed. The most important thing that people have experienced, later on I will again explain it in some detail. Sometimes there is a big hype of having discovered a big drug for some ailment, say blood cancer or something like that. It works fantastically well in the initial trials given to the humans. After a few years, you only find that there are other mutations that make these standard drugs ineffective. So, the patients, in simple terms, the patients ultimately develop resistance, and so at the doses given in the initial trials which were so successful, these become ineffective. So, mutation in the targeted protein, what is the reason? The reason is mutations. They take many mutations as a mechanism of resistance. Once you give drugs, they may be susceptible in the initial stages. After some time, they develop resistance by way of incurring some mutations which make them resist the drug. So, that is how it is done. They render the drug ineffective ultimately. If there is a new mutation that renders the drug ineffective. This happened in many cases. One of the cases we will discuss that in the case of some blood cancers. I think it is coming in the next or few more slides. Then as I mentioned again, efflux of the drug. Cancer cells expressing certain channels can pump out the anti-cancer drug, and this will escape and the cells will automatically proliferate. The other challenge is inability of the drug to affect the tumor stem cells, the so called cancer stem cells, which are a minority. They are very small in number. If you take the cell culture systems, for more than million cells of that cancer cells, there may be 1 or 2 or some 10 cancer stem cells. So, very difficult to isolate them actually from cell culture systems, because most of us are working with cell culture. It is very difficult to. So, people have often gone to another area which is like stem cell like cells. Do you know what they are? They are called spheroid formation. So, they also have more or less stem cell like characteristics. So, people form the spheroids and then check the effect of the chemicals on them, instead of isolating the cancer stem cells, which are difficult to isolate because they are very small in number. That is what we practically do it. You will see that by flow cytometry and all that, people will isolate these cancer stem cells, but not many are doing that. They will do this spheroid formation, which also gives more or less similar results. There is another therapy, I also mentioned about this earlier, so called combinatorial therapy. The existing drugs are there, you give something to because the existing drugs, many of them are very toxic. Taxol or many other drugs are very toxic. If you can reduce that dose, still achieve the same therapeutic effect, by giving some non-toxic compound such as curcumin for example, it can effectively reduce the dose of the standard drug, but achieve the same clinical result. So, that is possible. Many drugs are there, people have tried. Even if you do not do that, even among the existing conventional therapies, for example, you could combine chemotherapy with radiation. Maybe you do not want to give so much radiation because radiation is also very dangerous after a certain dose, right. So, give small amount of radiation and then give a little bit of chemotherapy also, depending on the patient. As I told you, old patient, you cannot give so much radiation, you cannot give so much chemotherapy also. So, a combination works better in those cases, either by combining the standard methodologies or by combining new molecularly targeted therapies along with the conventional therapy. This is what is called combinatorial therapy. It is a strategy aimed at maximizing the cure or survival rate and minimizing the side effects and toxicity. So, this is the purpose. Large doses of one drug can cause unacceptable side effects naturally. One example given here is cyclophosphamide in high concentrations for breast cancer therapy resulted in 5 to 6 fold increase in the risk of another cancer, AML. You are treating breast cancer, but you are ending up with the AML if you use it with the high concentrations. That is what it is. Instead, multiple drugs targeting different pathways at much lower concentrations may be more effective while reducing the side effects to tolerable limits range. So, this is what is the aim. One more interesting aspect in the treatment is that all of you know that the cancer cells are poorly differentiated. So, if you induce differentiation in them, you may restore the normal function. So, inducing differentiation may be one strategy to treat cancer, because the cancer cells are poorly differentiated. If you induce differentiation, then they may become normal. So, that is the idea. One example, a very successful therapy in this way is for acute promyelocytic leukemia. What is called all trans retinoic acid? Do you remember is there any spark by looking at the structure? This is very similar to, not rhodopsin, vitamin A, yeah. I think you can check that. All trans retinoic acid induces undifferentiated leukemic blast cells into to differentiate into neutrophils. It targets the PML, that is promyelocytic leukemia. Retinoic, RAR means retinoic acid receptor fusion protein. What happens is, in PML there is a fusion protein, but you have to target the receptor for inducing the differentiation. So, that is what is done. Now, from promyelocytes you get the polymorphonuclear cells, which are the neutrophils. So, that way the condition can be alleviated. This is the drug I was telling, the successful story, imatinib mesylate, which is also called Gleevec. It targets so called, we will talk about it later also, BCR-ABL fusion protein, a product of the Philadelphia chromosome in chronic myelogenous leukemia. So, this is a drug that was given. Immediately there was a big hype when the FDA, so called Food Drug Administration in the US, which usually gives the permission to use the drugs. So, their approval is necessary before you use the drug. So, when this was given, there was a big hype, all the newspapers and all that big headlines were there, but only to end up with some 40 mutations have been discovered that made these drugs ineffective in various patients ultimately. Now, what they will do, this is the first generation, then they will make some modifications in the structure of the drug, that is second generation drug, and then third generation, fourth generation, something like that. The ultimate aim is whether by making these modifications are we able to overcome these mutations. Some of them have been successfully treated, even under mutation. Some drugs have second generation, third generation drugs have worked against these mutations. So, people are working on that. The structure of the compound imatinib was optimized to improve binding to the catalytic cleft of the ABL tyrosine kinase, because this is acting against that so called ABL means Abelson tyrosine kinase domain, that BCR later on I will talk about that breakpoint cluster region that is there in this chromosome 922 fusion. We will talk about that later also. This is the structure of Gleevec. The N terminal catalytic cleft and C terminal is there, the activation loop, and so the ATP binding site can be prevented. The people have used this methodology in cell line models also to improve upon. We are talking about if there are mutations, how people are tackling it. Gleevec is known. Can you make anything better? First of all, to say that Gleevec is very effective against cancer cells but not normal cells, they have used this cell culture system, which is called BAF3 murine pre-B lymphocytes. They are IL-3 dependent cells. Once you add IL-3, the cells proliferate and thrive. If you remove IL-3, the cells will die through apoptosis. Now, you add Gleevec and IL-3, the cells will proliferate, which means why they are doing this is they want to show that Gleevec is not toxic to BAF3 cells. BAF3 cells are something like normal cells. Now, they are not killing them, they are not intrinsically toxic to them. Now, remove IL-3, transduce the BCR-ABL, which is the culprit in that cancer. Once you introduce BCR-ABL protein, that is the culprit that will convert these cells into cancer cells, because it is a tyrosine kinase. It will give proliferating signals. Now, even if you remove IL-3, the cells will proliferate, because BCR-ABL, if it is there, it is an oncogene. So, once you introduce that, the cells will proliferate. So, that is what happens. It can, in other words, it can replace IL-3. You do not need IL-3 anymore. Remember, I told you these are IL-3 dependent. Even if you do not add IL-3, because BCR-ABL is there, they will grow. Now, keep IL-3 and add Gleevec, cells proliferate and thrive. Therefore, cells receiving IL-3, if you put back IL-3, to some extent it can stimulate, because it can nullify the effect. Therefore, can tolerate shutdown by BCR-ABL by Gleevec. Gleevec is shutting down the BCR-ABL, but if you give IL-3, it can relieve that inhibition. You inhibit the inhibitor, thereby you can activate. So, these are the experiments people do, so that if you have a modified Gleevec, you can test it out through this system, cell culture system. They have tested with Gleevec, but if you have modified with that particular mutant or something, you can check out using this methodology. That is what is shown here. EGF antagonists are very important. I have already mentioned one such inhibitor that you must remember is called erlotinib. I will tell you also one clue. If the name, commercial name ends with IB, it is a chemical. If it ends with AB, especially MAB, it means monoclonal antibody. some names are there, I am not getting the particular name. I will tell you as we go along. Herceptin is one such thing. They have a particular name which ends with MAB because it is a monoclonal antibody. Whenever it ends with IB, it means a chemical. Irisa, Tersava, all those things, that is Gefitinib, Erlotinib, these are all some commercial names. They are low molecular weight tyrosine kinase inhibitors. Structures are shown here. They are basically some quinazolone compounds. Similarly, you could use proteasomal inhibitors. Originally intended to be a palliative theory, but serendipitously they have discovered that it is useful in cancer therapy also. Velcade is a famous example. Velcade is the drug. You can understand this since I have taught you NF-kappa B signaling. The many signals which can activate NF-kappa B by activating the kinase that phosphorylates I-kappa B. It's called IKK, which is a complex, IKK complex. That many signals can activate that. If that happens, I-kappa B gets phosphorylated in the N-terminal serine residues, 2 residues, and then the I-kappa B gets degraded by ubiquitination through proteasomal 26S degradation. So, this is the pathway, right? This is normal. So, you get ultimately NF-kappa B goes and binds and produces anti-apoptotic genes. This part you will easily understand. Now, if you give Velcade, it prevents this ubiquitination and consequent degradation. So, NF-kappa B is inactivated. So, the cells can die through apoptosis because the anti-apoptotic factor is inhibited now. So, it becomes apoptotic. It is a simple shifting of balance between pro-apoptotic and anti-apoptotic systems. Here anti-apoptotic system is shifted to apoptotic system, that is it. So, the cells die because you are preventing the degradation of I-kappa B. If you prevent that with Velcade, then NF-kappa B cannot be active, right, because I-kappa B has to be degraded for NF-kappa B to be active. Now, you are degrading the degradating machinery. So, ultimately you are activating that, that is the idea. You are not activating, sorry, you are not activating NF-kappa B here, you are inhibiting, right, sorry. So, ultimately apoptosis, okay. There are also gene therapies, siRNAs. I think we have crossed the time, we will kind of stop here. Almost we are done. Just to note down this siRNAs, miRNA mimics, viral vectors can also be used. Anyway, we have some more things, diagnosis, markers and all that. I will talk about it in the next class.